Thank you very much. I would like to thank very much all the organizers for inviting me and organizing this very key meeting for this a rare disease, but a very orphan disease. So I hope that we will ask some questions at the end of the meeting. So I'm adult nephrologist. So I have to quickly introduce the kidney to remind you that it's, the nephron is the functional unit of the kidney, and it is a very complex structure, and there is about 1 million nephrons per kidney. And it begins with the glomerulus, which is key for plasma ultrafiltration, and it is followed by tubules that are very distinct functional properties to produce a final urine that is contain all what is necessary to maintain body homeostasis. What about the expression of type 4 collagen in the kidney? As in other organs, kidney is an organ that contains collagen 4 in the basement membrane of the tubule, the glomerulus, the vessels, and the 112 molecules that is ubiquitously expressed outside the kidney is also highly expressed in the basement membrane of the tubule, of the vessels, of the Bowman capsules that line the glomerulus. And in adult glomerulus, however, the glomerular basement membrane is mainly contains the 2, 3, 5 type 4 collagen molecules, but in the embryonic glomeruli, the 112 molecules is the only one type 4 collagen of the GBM. So in the kidney, as in the other organs, type 4 collagen play a key role, and especially the 112 molecules during embryogenesis. It is necessary to build the complex architectural organization of the mature kidney. And in the mature kidney, the 6 isoforms are very important to support kidney functions, with in glomeruli to support ultrafiltration, tubules to equilibrate water and electrolytes, and also it is very important for blood pressure regulation. Besides the structural role, there is also a signaling role of type 4 collagen network during physiological and pathological process, for example, angiogenesis and others, but few is known for this signaling role yet. So, as a nephrologist, we are very aware about another type 4 collagen inherited disease, which is Alport syndrome, which is due to gene defects encoding the 3, 4, 5 type 4 collagen chains. And in these syndromes, it associates a glomerular disease characterized by hematuria, proteinuria, and in the severe form, chronic and end-stage renal disease, but also sensorineural hearing loss and various health defects linked to the restricted expression of these type 4 collagen isoforms in the GBM, in the cochlea, and in different segments of the eye. So we, as a nephrologist, we have taken poor attention in the 112 type 4 molecules. And what we learned from first preclinical mice model, that's finally only mice with heterozygous mutation with deletion of exon 41 shows subclinical kidney defect with low-level albuminuria and mild defect of the glomerular basement membrane. For us, the story begins with this large family that was followed in our nephrologic center since 4 decades with these 2 first patients who presented a kidney disease. I will detail the renal presentation. And the kidney disease co-segregate with other extrarenal manifestations, which associate retinal arteriolar tortuosity, cerebral small vessel disease that was clinically perceived as symptomatic, cerebral aneurysms, very similar to the one we discussed previously, muscle cramps, and renal phenomena. What about the kidney disease? The kidney disease in all affected patients presented was characterized by hematuria that appear early in childhood, and in most patients they also show renal cysts, defining a multicystic kidney disease in most patients. And only in the older patient, we've observed the appearance of proteinuria, hypertension, chronic kidney disease, and at least 4 patients now end-stage kidney disease. We have the opportunity to make a kidney biopsy in young patients. It is not possible to make kidney biopsy in patients with multicystic kidney disease because of the risk of hemorrhage. And what we observed, by light microscopy, we didn't see any gross abnormalities of the glomerulus or the tubules, except the presence of red blood cells in tubular section, which reflect hematuria. And it is only by electron microscopy analysis that we observed huge basement membrane alteration of the tubules, of the Bowman capsules, which is this structure, of the vessels, including arterioles and capillaries, but we didn't see any abnormality of the major glomerular basement membrane, which is not surprising because, as you remember, 112 molecules is only very weakly expressed in the adult GBM. And when we met this family, several linkage analyses with, of course, Alport locus, but also with locus containing genes encoding for matrix protein. And finally, we test the linkage for COL4A1 and identified a heterozygous missense mutation that substitute a glycine residue. So we then rapidly collect other family or patient presented with the same phenotypical presentation, and we call this syndrome ANAC syndrome, as you know, for hereditary angiopathy, nephropathy, aneurysm, and cramps. And it was very surprising to observe that all the mutations affect a glycine residue that are closely localized in exon 24 and 25. And very interestingly, these residues are located with the domain, a conformational domain of the triple helix, which is called CB3 domain. And this domain is characterized by the presence of several integrin binding sites, suggesting a potential genotype-phenotype correlation in ANAC syndrome. Very recently, a Japanese group also reported a family with the same phenotype and also a glycine substitution in the same gene location. Just to go quickly, but it's very important to understand the potential sign of progression of the renal disease, is the phenotypic presentation of the kidney disease in the patient with ANAC. Mostly all patients have hematuria, which appear early in childhood and persist through flight. Some patients have gross episodes of hematuria. They also have renal cyst, defining a multicystic kidney disease. Regarding the other kidney signs, you can see that only a few patients have proteinuria that appear later in life, mostly after 50 years, and it is sometimes associated with hypertension, and it seems to be one way of progression to chronic kidney disease and even in-stage renal disease. And as you see, we have now 4 patients, 3 of this first family and 1 of this family that develop end-stage renal disease. So what about, so it is the kidney phenotype in ANAC patients. Hematuria and kidney cysts are highly penetrant, and what I call the progressive kidney phenotype is less frequently observed. It progresses with age, and the proteinuria is obviously a first step potential to chronic kidney disease and the last stage of renal disease. What about kidney manifestation with COL4A1 pathogenic variant outside exon 24 and 25? It is far less frequently reported. Is it less frequently screened, low penetrance, less severe, unpublished? I don't know, but we have, of course, report of hematuria, hypertension. We have to take care about a potential fortuitous association. It has been also described congenital urinary tract abnormalities, multicystic kidney disease, and end-stage renal disease have been exceptionally reported, except in this very interesting family published in 2016 by Denigel in London. It is a Cyprus family with a mutation of the non-collagenous domain, Frameshift mutation in the non-collagenous domain of the protein. And you can see that they don't have an ANAC syndrome, they don't have muscle cramps, they don't have retinal tortuosity. However, they have a very severe renal presentation with almost all patients presented with hematuria, renal cyst, less frequently proteinuria, and several patients, mostly older patients, develop end-stage renal disease. What about kidney disease associated with COL4A2 pathogenic variant? To my knowledge, there is only 1 family with hematuria and 1 isolated renal cyst. What we learned from ANAC mice were to understand the pathophysiology of organ involvement in ANAC. We generate mice with mutation, with an ANAC mutation. The phenotype at birth is less severe than the one reported by Doug Gould. And when looking at the kidney phenotype, we observe in newborn mice hematuria, huge albuminuria, and delayed glomerulogenesis. And probably the delayed glomerulogenesis is due to the fact that in mice, kidney is not fully differentiated at birth. It is different from what we observe in human. In adult mice, we observed hypotension and also a multicystic kidney disease, and it was very interesting because the cysts, usually in cystic kidney disease, cysts are developing from the tubules. Here we can see that the cysts are developing from the glomeruli and probably is related to abnormalities of the Bowman capsules BM that are exposed to high pressure of ultrafiltration. There was also perivascular inflammation. This morning we asked for inflammation in this disease, and it was very surprising to observe a very dense inflammatory infiltration around these arterioles. So, how to screen kidney manifestation in COL4A1-A2 related disease? You have to check for familial history of kidney disease. to check for risk factor for kidney disease, because you can have this inherited disease and more common kidney disease. And especially, it is important for the care of this patient and preventing progression of the kidney disease. Of course, history of microscopic hematuria is important to check. And most important is blood pressure evaluation, not only for the kidney, but for the global vascular risk, to check for serum creatinine that allows the estimation of the glomerular filtration rate, and urine analysis. Deep-seq may be informative for the presence of albuminuria and hemoglobinuria, and if positive, you have to confirm absolutely that analysis of urine sediment to confirm hematuria and to quantify proteinuria. And last, US kidney is very performant to detect renal cyst as well as potential congenital abnormalities of the urinary tract. When to screen? At diagnosis in all subjects with COL4A1, COL4A2 pathogenic variant. In patients with Annex syndrome, due to high penetrance of the kidney phenotype, I recommend the yearly evaluation of GFR, blood pressure, and proteinuria. Repeated morphologic evaluation of the cystic kidney disease is not required. It will not inform about the outcome of the kidney disease. And in addition, hematuria will persist, and it is not a sign of severity. In patients with a pathogenic variant located in other region of the gene, if you have a normal kidney screening in children, please repeat the screening in young adults, because especially renal cysts may escape from early screening. In adults with normal screening, I think that only regular evaluation of blood pressures is required, mainly for the cardiovascular risk in this patient. And of course, if there is any kidney abnormality in this patient, you have to follow a yearly evaluation of kidney parameters. Quickly, how to treat? So there is, of course, not yet specific therapy, but you have to propose nephroprotective approach. You know, in many kidney diseases, unfortunately, we don't have curative therapy, but the nephroprotective therapy are very, very efficient to prevent progression of kidney disease. And for that, you have to fight to all risk factors of kidney disease and cardiovascular disease. Treat hypertension with an objective of blood pressure below 138. Stop smoking, treat hypercholesterolemia, diabetes. Avoid as possible non-steroidal anti-inflammatory drugs, and take care of other nephrotoxic drugs and control overweight and obesity. And you have to refer to a nephrologist in case of proteinuria, even low level of proteinuria, because now we have therapy like a blocker of renin-angiotensin systems or inhibitors of SGLT1 that are very, very efficient to control proteinuria, which is the first step to a chronic kidney disease evolution. And in case of decreased GFR below 70 and multicystic kidney disease, I think the patient must be evaluated and followed by a nephrologist. So in conclusion, kidney is a potential target organ in COL4A1 and COL4A2 related disease. However, take care to not miss a differential diagnosis of the inherited disease, and particularly in case of multicystic kidney disease, it could be important to check for mutation in PKD1, PKD2 that are involved in frequent autosomal dominant polycystic kidney disease. Second important thing is kidney manifestations are usually clinically silent, especially at early stage. So kidney screening is absolutely required in this patient, and you have to repeat screening even if normal in childhood, in children at the adult age. Kidney disease is highly prevalent in Annac syndrome, and this highly suggests a genotype-phenotype correlation. Hematuria and kidney cysts are common, not predictive to a severe kidney outcome, and however, proteinuria may anticipate CKD progression. Prevention and treatment of kidney and cardiovascular risk factor is key to prevent progression of existing kidney disease, of course, but also to limit the vascular burden of the disease. So I will conclude to acknowledge all the people who contribute to the description and the work around Annac syndrome, especially Pierre Ronco, and I would like also to dedicate this presentation to Michel and Alain, which belong to the first family. And this family are our family since, for me, 20 years. And it's usually very important to progress to help them to get better. Thank you very much.